Hello, everyone. Thank you for joining the webinar. My name is Kate Morales, and I am the Senior Program Director at the Hepatitis B Foundation and Director of Hep B United. We're excited to present you today's webinar on collecting and using hepatitis B screening data for research and policy. Just to give you an overview of Hep B United, we are co-chaired by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. Hep B United is a national coalition to address the public health challenge of hepatitis B, which is the leading cause of liver cancer and a major health disparity among Asian Americans and Pacific Islanders. Our goal is to support and leverage the success of local community coalitions across the U.S. to increase Hep B awareness, screening, vaccination, and linkage to care, again, with the White House Initiative on Asian Americans and the Pacific Islanders. Today, we're going to be discussing best practices for data collection at community-based hepatitis B screening settings, applying for institutional review board approval, and managing and publishing hepatitis B data. I will introduce all of our presenters before we get started. We have with us today Ms. Christine Harley, who is the Senior Policy Advisor at the White House Initiative on Asian Americans and Pacific Islanders, Dr. Amy Jessup, an associate professor at the University of the Sciences. Amy is also the executive director of HepTrek, or Hepatitis Treatment Research and Education Center. Dr. Karen Kim, professor of medicine at the University of Chicago and board president of the Asian Health Coalition in Chicago. And finally, Ms. Cherry Cohen, who is the director of public health at the Hepatitis B Foundation. Before we get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode and will be muted during the presentations. You may use the conference line to limit background noise. The call-in number is up on your screen. And you may submit questions in writing during the presentations by typing them in the chat box in the lower left-hand corner of your screen. And please indicate to whom the question is directed. We will be reviewing them as they come in, and we'll have a Q&A period after the presentations. And finally, today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. And with that, I'll turn it over to our co-sponsor, Chris Harley, for opening remarks from the White House Initiative on Asian Americans and Pacific Islanders.
Great. Thanks, Kate, and good afternoon to everyone. I just want to thank the Hep B United Coalition for their efforts in continuing to lift up this issue and putting together another really great and informative webinar on efforts to eradicate Hep B as a health disparity for AAPIs. We here at the White House Initiative on Asian Americans and Pacific Islanders is really pleased to continue to support and co-sponsor these webinars. And we're in particular very glad to join today's webinar on collecting and using hepatitis B screening data for research and policy, because it fits right really within one of the core areas of work that the initiative engages in. So, we at the initiative work on several key issue priorities for the AAPI community, including health, immigration, education, and civil rights, but also on these cross-cutting priority areas that are important across issue areas and across federal agencies. So data disaggregation or advancing the research, data collection, analysis, and dissemination for Asian Americans, Native Hawaiians, and Pacific Islanders is really one of those cross-cutting areas. And so for us, improving the current
attendees are muted.
Improving the current practice of federal data collection to aggregate AAPI subgroup data and reveal the disparities of underserved AAPI communities ranks among one of our highest priorities. And so we've been working very hard to promote data disaggregation across the federal government and trying to see what data sets can be disaggregated and how to best highlight the needs of our underserved communities with our federal partners. So, while we know that the AAPI community is one of the fastest growing racial groups in the country, and that rapid growth indicates an urgent need to address the daily issues and challenges of our community, we also recognize that AAPIs remain one of the most understudied racial groups in the country. And so it's really critically important to collect, analyze, and disseminate the data on AAPIs to help reveal and address the masked needs that exist among AAPI subgroup data on AAPIs has really been part of the reason that there continues to be this perpetual model minority myth. This notion that all AAPIs are self-sufficient, well-educated, and healthy. And it's, obviously this is also one of the key reasons that the hepatitis B epidemic in AAPI communities has struggled to gain visibility. And until advocates and coalitions such as Hep B United, provided the data and statistics to raise the profile of this disease on AAPI communities, it was not understood to be an issue for governmental agencies to pay attention to. And so, although I myself am not really a data person, one of the things that I recognize is that in order to make a good policy for AAPIs, we need good data. And in fact, I think compelling or surprising statistics is really one of the number one ways to gain the attention of policymakers and encourage them to take action. So having strong data and strong statistics and stories can also be used by federal decision makers to justify the allocation resources that they have to address, key concerns and priorities. So, for example, it was the data provided by Hep B advocates that encouraged HHS to create their action plan combating the silent epidemic of viral hepatitis. So I, for one, am really excited to hear from the rest of the speakers, Amy, Karen, and Cherry, to discuss how Hep B advocates can continue to really collect good data and, even more importantly, to translate that data into useful information that can help shape the actions that policymakers in the federal government make to address this issue. But before I turn it over, I just want to note that all of this background is really why the White House of our AAPI data tool, data.gov/AAPI. This is a website that you can now go to. It contains over 2,000 data sets and reports from nearly 50 different federal, state, county, and city sources pertaining to Asian American, Native Hawaiian, and Pacific Islander communities in one location. So data.gov/AAPI is now the most comprehensive hub of government data on AAPIs. It includes data from 27 federal agencies, including the U.S. Census Bureau, Department of Education, Department of Labor, and Department of Health and Human Services. And our goal is that this website helps create transparency around existing AAPI data and making it easily accessible to those who create tools and leverage resources to better serve AAPIs, and that it will help pave the way for greater collection, analysis, and dissemination of the information that is available on AAPI communities in a easily searchable database. And ultimately, our goal is that researchers and academics will be able to access this data for important research. Policymakers will be able to use it to create smarter plans and evidence-based models for engagement with the community, and that the broader community will have a more accurate story of the AAPI communities. And I also want to note that this isn't the only data disaggregation tool that's out there. Professor and world-renowned data geek Karthik Ramakrishnan has also developed AAPIdata.com. And the National Council on Asian Pacific Americans has a report called Best Practices Researching Asian Americans, Native Hawaiians, and Pacific Islanders, which include practices for effective community-based participatory research. So I hope that if you all are interested in data collection and disaggregation as it relates to addressing viral hepatitis, that you use these resources to help both gather and share data on hepatitis B. So this is my contact information, and I'll now turn it back to Kate and look forward to hearing from the other presenters. So thank you very much.
Thanks so much, Chris, for your support and really setting the stage for this discussion and stressing the importance of data collection, especially for Asian Americans and Pacific Islander communities. We'll now focus on the importance of collecting Hep B data and walk everyone through the actual process, especially if you're thinking about conducting research with your data. And we'll start with Amy Jessup, who will provide us an overview of the process of applying for Institutional Review Board approval. Amy?
Hey, everyone. I'm assuming you can hear me. Thanks for including me in this call. I'm thrilled to talk to you all, and I've been a long-time community advocate for people with viral hepatitis and for viral hepatitis research, so I'm particularly happy to talk to you today. I serve as the chair of the Institutional Review Board within my academic institution, which is the University of the Sciences in Philadelphia. And our institution is a little unique. It's full of health professions people. That's mostly what we have here. And many, many people come here to teach and go to school coming straight from community-based agencies or healthcare institutions where research and IRB issues aren't something they think about every day. So I think perhaps I have a perspective into where you all are coming from and what you might need to know. So I hope that this presentation helps you, and I'll be available at the end of the conference call today for questions if you have them. So what I wanted to talk with you about first is you probably heard of an IRB. If you haven't heard of the IRB, we'll talk about it a little bit as we roll on. But the IRBs are the result of federal regulations that were put forward in the early 1980s after release of this landmark publication called the Belmont Report. And the Belmont Report really looked at what happened with experiments known as the Tuskegee study in the United States, which really was one of the landmark, to use the same word again, landmark cases of ethical misconduct in the United States. It's by far not the only one, but it was one that came to light, and the amount and the egregiousness of ethical violations led to the federal government actually coming up with federal regulations to oversee protection of human subjects in research. So you can, on your own, look up the Belmont Report and read about that. So the Belmont Report guided this development of federal regulations. And the regulations regarding human subjects are under this, the designation of 45 CFR 46. So you can also Google that sometime if you want to see the whole document that guides protection of human subjects in research. And basically the foundation of it is looking at what is the basic ethics in human subjects research. And the main ethical principle is to make sure that whatever's being done to an individual, the potential benefits from that action outweigh the risks. And the benefits don't have to be to any given subject, not necessarily the person that you are using in your research, but that what you might learn from harm that could come to that individual can benefit society overall. So IRBs are charged with primarily looking to see if the benefit or potential benefit from projects that you propose outweigh the risks to the individuals involved in your study. Also, the other ethical principles are privacy. The right to privacy. Subjects have a right to keep their information private and to choose what information can be given to whom and when. And also that the participation is voluntary, that it's not coerced, and that it's informed. You know what you're agreeing to participate in. So those are the main ethical principles that guide IRB review and human subjects protection in research. And I'll also say just briefly that there are many states and local jurisdictions also have regulations about protection of human subjects in research, so you may need to learn about those as well. So the first thing that I hear from people who aren't clinical researchers and doing clinical trials is that, I am not researching on people. I'm not doing anything to people. So how much harm could I possibly cause? I'm just asking questions. And I used to think this myself when I was a laboratory researcher. And then when I moved to more social science, I realized that you can do a lot of harm just from your questions and what you do with the information derived from questions. There can be social harm, emotional harm. And for Hep B screening, obvious ones are, what if other people learned of one of your subjects' hepatitis status or their HIV status or something else about their health or their behavior or their background? You could cause quite a bit of social harm. There could be legal harm. If someone is in a position where they must document their hepatitis status, they could end up in legal harm. They could end up in financial harm. If someone learns, maybe with insurance, if they learn that someone has hepatitis B and they didn't disclose it on their insurance form, they could lose their health insurance. And then there's moral harm. Will participation in your study lead your subject to potential unethical behavior? And for something like hepatitis B, it could be once someone learns of their status and they have unprotected sex with someone, or someone is exposed to their blood and they don't inform them of the risk, that's unethical behavior, and that's a moral harm that could come to both your subject and the person they interact with. So there's a duty for researchers to minimize these potential risks. The next question I always get, so is what I'm doing really research? And do I really need to have this review of my protocol before I'm allowed to do it? And I say, maybe you do, maybe you don't. Let's talk about what it is. So most of us think we know what research is, but as far as these federal regulations go, research means a very specific thing, and it's the federal definition of research, which I have on the slide. And it's a systematic investigation that's designed to contribute to generalizable knowledge. So any project that you conduct and you have an intent, you've designed it and you've organized it, and then you have an intent to share the information that you gather beyond those involved with your project, then you probably have research. And that sharing of information includes publishing your results in a journal, presenting your results in any public forum, whether it's a professional setting or maybe a meeting with a policymaker. Anybody who's outside of the realm of your exact project and the people in it is a public dissemination of your work. The next thing is, do you have human subjects? And according to the federal government in CFR 46, a human subject is a living person, so dead people don't count as human subjects, living individual about whom an investigator obtains data either by interacting with that person or doing an intervention, doing something to them or on them. And not just that, you don't have to actually interact with that human being directly. You could have interaction or intervention using that person's identifiable private information. So their private health information, their name, their image, any of those things, they are a human subject. So with that said, next question is, well, do I need it? I think I have research. I think it involves human subjects. Do I need to get IRB approval? And I would say maybe. And you need to ask yourself a series of questions. So what I have on this slide is number 1 and number 2 is the convoluted legal language that comes out of the federal regulations. And really what it's saying is that if you're doing research that's conducted or supported by the federal government or an agency of the federal government, then you must comply with the regulations for IRB review. Number 2, if you're doing research that maybe it's not conducted or supported by a federal agency, but it's subject to the regulation as defined in the articles, then you also need to do this. So what does all this gobbledygook mean? So if you are a government agency and you are conducting human subjects research, you must have IRB approval. If you are a program that receives federal money for the project that you're doing, first question I'll ask you is it okay to do research with the funds? Many CDC grants specifically say this is not for research purposes, so you want to check on that first. And if you can use it for research purposes, then yes, you need IRB review. Has your organization received federal money for other projects? Then you may fall into some of those categories that were in number 2 on the slide before, and you probably need to have IRB review. The next one is, does your institution have an agreement, a written agreement with the U.S. Department of Health and Human Services about review of research conducted at your facilities or by the people associated with your facility? If yes, then you probably need to do this. And then something that's a little more nebulous out there is that when you go to disseminate your research findings and you do it through journals or professional associations, very often they require the researchers to have had IRB approval for the work that they did. And it's important to recognize at this point that approval has to be obtained before the research begins. IRBs can't retroactively approve things that were already done. I'm sure that was all confusing. The next set of questions that I usually get from people that I interact with about IRB is, well, I do this work every day in my office. What makes it different this time? Why do I need to have IRB review for something that I routinely do? Same activities, and now you're telling me I need IRB review. And my answer is that there's a difference between a usual practice and research. So activities that you would conduct if you were a medical professional, for example, at my institution, we have a large physical therapy department. Activities that they may do with a patient in their physical therapy practice falls under the, and they have a medical order to do that, that falls under the category of clinical practice, right? They're using standard approved practices to treat a condition for a patient that came in and asked for treatment of this condition. Clinical practice, that is not research. If you're doing an activity in the community, I often go out and do hepatitis immunizations in the community. I do not need IRB approval for that. That's just a community practice. It's something that I do. Evaluations are the same thing. If you're conducting an evaluation to determine how well a program works or what program needs are, that's usually evaluation practice. But once you set out to do these things and you say, you know, I think I might want to share what I learn with others, it becomes research. So evaluation activities can be either just evaluation practice or research, depending on your intention. Things that are not research would be customer satisfaction surveys. So if you just ask people, how did you like our services, that's not research. If you do anonymous evaluation of a standard type of educational activity, that's not research, and you wouldn't need IRB approval. If you want to observe what people are doing in a public place, and you're not doing something to sort of deceive them or get them to act in a certain way, then that's not research. The trickiest one of these is review of public service programs. Usually, that's not research, but sometimes, depending on how an agency might approach it and what they're asking and what their intention is, it could sometimes fall into the research category. So sort of to wrap it up at the end, the same activity that you do, what you actually do with a person, in one scenario could be practice, and in another scenario could be research. It all depends on what your intention is. For those of you who don't know what an IRB is, it's an institutional review board. Every institution which has an IRB should have an agreement with the federal government and that is usually called a Federal Wide Assurance, or FWA. And that agreement with the federal government and between the federal government and the agency will outline what research is and is not covered, quote unquote, under the agreement that that institution has with the federal government. And so those covered things generally apply to some institutions will, in their agreement, will say we only will review protocols for research that's federally funded. Some will say we're going to review all human subjects research, whether or not it's federally funded. And some say we will review all human subjects research, funded or not, except for that which meets certain criteria for quote-unquote exemption, which I have a slide about later. Okay, so if you're working at an institution that already has the IRB that's registered with the federal government, you might want to find out what things are covered and not covered. And then the IRB is charged, as I said earlier, with protecting the people that are involved in research that are under the auspices of your institution. The IRB, or the CFR 46, allows for 3 types of review: exempt review, expedited review, and full review. Each type requires a different level of review and takes a different amount of time, with the full review being the most expansive, expensive, and time-consuming. And to decide which thing you fall under, you would look at what is the likelihood and type of harm to your subjects, and the type of subjects that are in your research. So there are certain groups of people in the U.S. that are called protected classes. And if you do research including them, it always ends up in this full review category. And those, I think for the purposes of viral hepatitis, those most important ones are children, pregnant women, people who have mental disorders that would impact their ability to consent. Other ones include prisoners. That's all I can think of. Sorry, there's a list of them, but those are the primary ones that you would probably encounter. Here in our institution, our agreement with the federal government is we will review all research that's conducted, federally funded or not, and for all types, whether it would meet this criteria for exemption or not. I mentioned there's different types of review. The chart on this slide outlines what criteria have to be met for the different types of review. And again, it's great to have these exempt reviews. It exempts you from a lot of further regulation in the future. So you can look at these at your leisure. And then if you are going to submit an IRB protocol to an IRB, either within your institution, to a private IRB that is out there and that you can contract with to review your research, or if you're going to go in with an IRB with one of your collaborators. Sitting on the IRB, I would say these are important tips for completing your documents. Make sure you answer all the questions that are asked of you. If you don't know how to answer the question, if you don't know what it means, ask somebody first before you submit it. The language that you use in your documents should be understandable to a layperson who is not from your field. The IRB will be made up of lots of different kinds of people with different expertise, and they very likely will not understand jargon in your field. Similar thing is consent forms for your subjects really must be written at a reading level and using language that's appropriate for your subjects pool. And you must show that the methods that you're going to use in your research will allow you to meet the objectives you were setting out to meet. And that if your design is poor or it's hard to follow, the IRB is likely to say there's way too much risk for potential benefit here. We can't see benefit because the design is so poor. We're not going to allow this to happen. It should be clear, it should be consistent, and it should be complete. And again, all IRBs prefer that you ask questions before you submit something so that you don't start a review process, have to get denied, and start over again. And I think that was it for me. So thank you for the opportunity to speak with you. I know I gave you a lot of legal mumbo jumbo, and I hope that it was helpful to you.
Thanks so much, Amy. That was really helpful. And just as a reminder for participants, if you have a question during any of our presentations or for Amy, please box on the lower left-hand corner, and we will take them in the order that they come in during the Q&A period. And with that,
my contact information is on the slide, and feel free to contact me with questions if you have them in the future. I'm always happy to help.
Great, thank you, and we'll be sure to share copies of the presentation slides with everyone after. And with the process in mind, we will turn it over to Dr. Karen Kim, who will go into more of the nuts and bolts of collecting Hep B data for research. Karen?
Yeah, great. Thanks for having me. So I'm really actually going to do a kind of a bigger overview. I think it would be hard to get too granular in what we think about, but maybe a compelling reason why we need to think about data collection. So let me just go over again some of the problems that make us think that data collection is important. So there's really a paucity of data for Asian American Pacific Islander subgroups, and I'm sure many of you know that. And often when the data is collected, or when there's reports that are released, data on Asian Pacific Islanders are either reported as not collected, are statistically unreliable, or the data is just not there. It's not been analyzed. And this can result in marginal funding for research for Asian American Pacific Islanders, which I think impact all of our communities. And I think the sad thing is of only 10% of all the research studying Asian Americans are ever reported. That is that so many of us, myself included, who are doing really outstanding community-based work just don't take it the next step to actually disseminate that information in a meaningful way. And we heard that good data leads to good policies, but good data also leads to good funding, which is an area that I think we're all very interested in. And if you look at sort of what this results in, if you look at kind of a very broad database of all the articles, Medline articles between 1966 and 2000, and there are over 10 million articles, and only 0.01% directly involve Asian American health, and that's really sad given our rapidly growing population. And if you look at the list of all federal grants between 1986 and 2000, of which there are about 150,000, only 0.2% address Asian American health. So while this is sad, I think this is also an incredible opportunity for us. And if you look at U.S. Foundation grants, for instance, just in 2004, only 0.4% fund Asian American Pacific Islander research. And so I think the importance here is that, as my research director says, no data, no problem. And I think we know that that's not the case, and that we really need to be able to think of ways to get our information out. So hepatitis B screening in the community is incredibly important. We know that often community-based screening programs and community-based programs in general are very effective and often more successful than what we see in academic health centers or medical centers, because I think being able to have that community context, the language-specific needs, and then cultural competency are very important to be able to get our communities to think about screening. And most of these screenings, particularly hepatitis B screenings, can inform sort of the local problem and often even local policies. And that's very important. But the problem is that we still are underreporting a lot of this information in terms of contributing to the academic literature. And you just heard a lot about sort of the institutional review board, and at times that can sound very intimidating. But the reality is that a lot of times if you have collected survey information that is de-identified, you can get a very easy exempt from the IRB. And even though journals and reports don't like retrospective IRB approval, there are, depending on which groups you're working with, there are ways to take data that you already have and get it approved. I think the other thing I should say is that there are a lot of journals, particularly journals that will publish sort of convenient samples that are not requiring IRB approval, which I don't necessarily advocate, but I also think that it's important to get your data out. And however we can help you do that, I think is important. So you shouldn't be intimidated by the IRB process. In terms of how we should go about capturing data in the community, I think it's very important to plan very carefully before your screening event. You know that once the screening begins, chaos ensues. And so the better prepared you are to not only organize your event, but be ready to collect data, the better. So whether that's a pre-registration to make sure that your consent forms are there and that you have adequate bilingual materials. And I think bilingual materials are another potential barrier for getting through an IRB, because often the IRB is not used to seeing Asian materials, and often there's no real good standard of forward back translation for Asian information. And because of cost, we often have people who work with us do the translations, and this can often be seen as a barrier for Asian American health research when it comes to IRB approval. So that's where you have to work very closely with your IRB. I think it's also important to think that we often have only one time to collect the data, so we really need to be as accurate as possible, and that comes through planning. And I think many of us are involved in numerous screening events, and so it's important that we're consistent in our data collection methods, and so you don't sort of change your methodology during the middle of your data collection. So in terms of what you want to collect, it really depends on the questions that you're trying to ask. I think that it's very helpful to have sort of broad categories of demographics, race, ethnicity, particularly as granular as you can get in terms of not only sort of broad Asian categories, but disaggregated categories. I think immigration history, particularly for hepatitis B, is very important. SES factors, gender, education, medical history, risk factors for hepatitis, immunization history, and family history, all I think are things that you should consider in your screening that will help us better understand who's at risk and how can we decrease the incidence and prevalence of hepatitis B. I think it's important that you develop an easy-to-use intake form, because remember, once your screening starts, often even though you are doing this in a structure of thinking about research, often it's not your research assistants who are filling out these forms. It's community individuals who often speak the language of the participants. And so I think it's important to have an easy-to-follow intake form. Often those intake forms may be bilingual, and it's always okay to transfer data off of your intake forms after the event. I think it's also important to know if you're collecting de-identified data, that is where you don't have the data particularly linked to an individual. You can do a number of different ways to code individuals if you have to link their survey with their results. But in terms of from a research perspective, often we don't actually need to know who the results belong to, as long as we have a way of capturing the data. So thinking of some way to de-identify the data if you are thinking about this in terms of research. Many times when we are partnering with community-based organizations and the people that we are screening are their clients, then we have allowed them to sort of handle the data and then give us de-identified data after the event. So there's many different ways to collaborate together. This is just an example of one of the forms that we're working with the CDC on a Hep B screening grant to just give you an idea of what your intake forms might look like. But again, I would imagine that there are many people on the line, and probably each one of us have a different intake form. It would be really, really nice to coordinate this effort nationally so we could have a much better idea of sort of what the prevalence and incidence of hepatitis B is across the country, because I know many of us are able to have very granular data at the local level. I think I'm going to just stop with take-home messages. So, I mean, I think I can't I can't emphasize enough the impact and the importance of community-based screening. I know that oftentimes there is a concern that there's not adequate linkage to care, or that community-based screenings are sort of a convenient sample that is not representative of the community. But I'll tell you that I think that this is an incredibly important and valuable source of information and data to help us better combat this disease. So community-based screening is important. I don't think data collection needs to be as challenging as we sometimes think about it, is if we are well prepared and if our forms are easy to input during our screening events. Cleaning the data for dissemination, which I think Sherry is going to talk about a little bit, is really critical for broader dissemination. And the cleaning data may include sort of understanding where the missing data points are, who has come to the same screening event 5 or 6 times, and we're just capturing the same individual. It's really important that the data that we use for dissemination is as accurate and pure as we can make it. And that's not always the easiest thing to do. I would also say that never forget that the ultimate goal of screening events is for patient care and hepatitis B control. And so while I think dissemination is critical to build sustainability, I think it's very important to not forget the reason that we're doing these events and the importance of the work that you're doing in the community. And I think the last point I'd say is that there are many ways to collaborate. I think that it could feel overwhelming to think about getting an IRB, creating your data capture forms, cleaning your data, and then thinking about creating a manuscript for dissemination if you don't have as much capacity to do so. And I think thinking about broader collaborations is really, really important, whether they're academic collaborations or foundation collaborations. I think that will really make this better. But I think the key is that the access to the community often comes from those who are probably on this phone, and I can't emphasize the importance of that group enough. Thank you.
Thanks so much, Karen. We definitely echo the importance of collaboration, especially when we know that Hep B data nationally is still something that we don't have enough of, and really appreciate your stressing that message. And finally, we'll turn to Sherry Cohen, who will walk us through prepping your data for research and publication. Sherry?
Thank you, Kate. I am going to talk a little bit about kind of once you do what you do once you have the data, and I'm not going to talk for very long. I think I just want to thank Chris and Amy and Karen for giving an overview and in terms of the importance of IRB and data collection and how you know what to do when. So I'm going to do a little bit of information about managing and publishing your data. So the first thing I wanted to talk about is when you're collecting data, obviously the most important thing is training your team. I know Karen mentioned, the people who might be collecting the data. So we're always very careful about training anyone who's going to be collecting data, entering data, or managing data. And we also we're very careful about limiting the number of people who actually enter and manage data just for consistency purposes. But whether you're doing this for research or not, I think you want to obviously keep organized records and good records, particularly if you're getting blood test results back to people. But if you are doing this in terms of research, or you even want to internally just evaluate your program and know what's happening, you want to make sure that you're taking the data back to your office, entering it into some kind of database internally, and then you can use it to analyze. Once your database is there, it's actually very simple to analyze and get a big picture or as detailed a picture of the data as you want. So we want to make sure that you're training all of your people who are going to be collecting, entering, or managing data. This is particularly important if you do have IRB approval. Anyone who is going to be handling your data at all need to have HIPAA certification training. First of all, it's a good idea even if you don't have IRB approval. And it's easy to get certification online. There are lots of free programs through universities. Usually you read a bunch of stuff online, you answer some questions, you take a quiz, and then you get a certification. And it's good usually for a couple of years. And I suggest that anyone who's going to be collecting or handling data get some kind of certification online. And then I also suggest that if you are, once you start collecting and using and managing data, that the person who's in charge of the project do some kind of systematic periodic review. And that's to make sure that data entry is happening correctly and accurately, and to make sure that, for instance, it's easy to say we're going to, particularly for groups that screen a lot of people, if you're screening a couple hundred or a couple thousand people within a month or a few months, it can be cumbersome to take all of that back and enter it. But at the same time, you don't want to forget about it and kind of leave those papers there forever and never get the data entered. So we do something monthly here where we have kind of a monthly check-in and a monthly review where we have we talk about the data, and then I actually go in and do some periodic review just to make sure that everything looks good and everything looks accurate. And the other thing I like to do, particularly if I'm having more than one person enter data over time, is do like a random selection. For instance, if there are 80, 90, 100, or 500 rows, I can look at maybe every 10th row that is in the data set, compare it to the original screening form, and just check for accuracy to make sure that things are being entered correctly. I just wanted to give people an overview of what a database might look like. So really the importance of creating a database, the main purpose of creating a database is to take words, you're taking verbal information and turning them into numbers so that you can analyze them and evaluate them. So I know Karen Kim had showed a picture of what their intake form was. Well, we have an intake form as well, and then when we get back to the office, we take all of the information from the intake form and we turn it into numbers, and then we put it into the database. So if you look here, you see the different columns represent the different components of our intake form: age, gender, language, ethnicity. I can tell you, for instance, if you look at the ethnicity column, 4 is the number that we have coded for Asian Pacific Islander. So that means all the people in that row that you see there are Asian Pacific Islander. And then if you look down to the second box there, you can see test before. Well, that was a question where we asked someone, have you ever been tested before? And a 1 would indicate yes, a 2 would indicate no, and a 3 would indicate I don't know. And so you can see this is really just a way of taking the intake form and turning it into a numerical database. When you do that, when you turn your intake form into a database, the first thing you do is create a code book. And a code book is going to be the guide for you, and it's going to help you enter all of your data and create kind of rules for your data. And the important thing about a code book is you do create it in the beginning, but it's a living document. So for instance, it can change over time as you need it to. So it can be as flexible as your data collection is. So these, I just kind of cut and pasted some of the components of our code book. So for instance, it tells you column C in my database is gender, and 1 is male and 2 is female. So whenever you would see a 1, that would indicate that that person was a male, and the 2 would be a female. So I wanted to look at multiple responses. So that is where things, questions that have one answer or a yes or no, they're kind of simple. But when you're getting to columns that have multiple responses, you need multiple columns for each response. And the purpose of the code book is you know exactly what each response means. So it's not as simple as a 1 is yes and a 2 is no. If you look at column T through V, you have spouse, mother, father, sibling, child, cousin, grandparent, and you can have, 20, 30 more if you wanted to. So this way, months or years down the line, if someone needed to look back and say, oh, gee, this column 7, it says number 7, what does that mean? You can always go back to your code book and say, oh, that means that their grandparent had hepatitis B. So that's the purpose of the code book. And we do have, we're very happy to share our code book if anyone wanted to. They can certainly, I have a line template for the database that we use, and we have the code book that we could share that people could use as a template for themselves. So the other thing we want to look at is handling non-compatible responses. So sometimes when people fill out the intake form, there are times that they may respond to questions in ways that don't necessarily make sense. So for instance, if you have a male who's filling out, "Are you pregnant?" he may say yes or no, or I don't know. And so in that case, your database isn't going to understand that he's a man and that he shouldn't have answered that question. But your data entry person does understand that. So in the cases of those kinds of questions, the most important thing is for the data management team to set up rules before you start entering your data. So we sat down and said, how are we going to handle this? If we have a man who answers a pregnancy question, what are we going to do? Are we going to leave it blank? Are we going to add another code? And so the most important thing is that everybody who's entering the data is doing it in the same way, and everybody's following the same rules so that you don't wind up with a database that's mismatched. This is also the same case for things like yes, no, or I don't know questions. One of the questions we have in our intake form is, have you ever been tested for hepatitis B? And so someone might say no. And then the next question is, what were your test results? And they may say, positive, I was told I had Hep B. So you see, you can have potential questions that just kind of don't jive with each other. So what we have to do internally is decide what we're going to do with that. Clearly, there was a mistake with one of those questions. What we do typically when we have a situation like that, we usually leave both responses blank because we never know which one is true. But that would be up to the team to do. So we talked a little bit about entering and managing data. I wanted to just quickly go over the idea of publishing. We all know that sharing our data with the world is one of the most important things we can do, particularly in furthering Asian Pacific Islander health and data collection. So when you're ready to publish, what you need to do is pick the right journal. Make sure you're picking a journal that publishes the kinds of projects that you have and the projects that you've done and the data that you've collected. Looking at past issues is really important because you can see what they've published and if their articles are similar to yours. There's something called an impact factor for every journal, which kind of evaluates them based upon the frequency of citations within their journal. And so the higher the impact factor, basically the more the journal is read. So you can look at impact factors as one of the ways that you can evaluate which journal you want to publish in. Another thing you want to think about is open access options and whether some journals do have open access for a fee. So you can think about whether you might have some funds to publish something via open access so that more people would have the opportunity to read it. And then when you're publishing, I think the important thing is to make sure that you are choosing authors who are not only involved in the study, but who are going to be involved in the preparation and editing of the publication. And it's a good idea to kind of pick out who's going to do what in advance so everybody knows what their role is. And then, of course, when you're ready to submit, every single journal article has an online format, and they're all different. So the most important thing is that you need to pay attention to detail and format your submission to that specific journal. And sometimes you can format something for a specific journal and it doesn't get accepted, and then you have to resubmit it to another journal, and you may have to change all the formatting. And that's just kind of part of what you do. And the final suggestion I have for publishing is most journals give you the option of suggesting reviewers, and I highly suggest using that. If you know people who are sort of expert in your field and who might be able to very favorably and very intelligently review your article, then I would suggest that you offer those names. Publishing really is not, my goal would be to tell everybody to publish. Some articles are short, and there are a lot of journals where you don't have to write an entire research article. They usually have smaller options, even if you wrote 1 or 2 pages. on what you were doing. It's really important, and it's not that scary once you get into it. I think that's it for me, Kate.
Great, thank you, Sherry. We will now begin the Q&A portion of the webinar. So as I mentioned, if you do have a question, please feel free to submit to us via the chat box and direct to whom the question is. If you do have one, please feel free to submit them now. I do have a few questions that came in during the presentations, and I believe this one is for Amy. If the question is, if you have IRB approval from your institution but are partnering with other institutions to do the research, do you need IRB approval from each institution, or does approval just from your institution cover the research project?
Hi, thanks for the question. In general, approval from one institution covers just that institution. So if you have, for example, if I was working with Sherry Cohen at Hep B Foundation, we would need approval from my institution and hers. However, not that long ago, the federal government added to the regulations and permits what they call a designated IRB. And if the IRBs agree, one of the IRBs can be named the IRB of record, and they just communicate if there's something bad happens with the other IRBs. But that decision is made at the IRB administrator level, so you have to ask the IRBs involved if they're willing to do that. And often they are. They want to decrease paperwork as well.
Okay. And that is in the case of a research that is receiving funding from federal funding. Is that right?
It depends on what your institution, so I had a slide about, if your institution can tell their agreement with the federal government. Are they going to review just federally funded research or all research or just certain types of research? So it depends, the different institutions could have different agreements, which makes things kind of difficult.
Okay,
so you have to ask. Yeah.
Okay. The next question I have is, I would really like to get data in my home country in Africa because there's no screening or strong policy in Hep B or C. Can you suggest some collaborations? Does anyone want to take that generally?
Online effectiveness is only 25%, whatever that means.
I will say, and I can take this. There is someone on the webinar who is conducting research in Malawi. I'm not sure which African country that you are based out of, but we can connect you with that person, and she is a partner of ours based in Boston, and so we can connect you. Another suggestion I have is you may want to check out the World Hepatitis Alliance, which may have more information or contacts for those that are doing work in Africa. So the next question I have, I think, is for Amy. What is a typical time frame to receive IRB approval?
So that will vary by institution to institution and the type of review that's needed. I know my answers aren't really very exact, are they? So if it falls into those categories that I said, if it falls into the exempt category, at my institution, it would take about 2 weeks. If it falls into the full review category, then it will take at least a month, and you might be required to come in and talk to the IRB about your project. So it's really helpful to kind of design your project to need the lowest level of review possible and still meet the objectives that you have for the study. So it varies from institution to institution. If you use an outside IRB that you pay for, they usually turn it around very quickly, often within a week.
Great. Thank you. Yes, and that's helpful, and it seems like it really depends on things. And finally, received is, Is there particular IRBs that often deal with API community-based research? Karen, Shari?
From the IRB perspective, say, institutions that are located in, IRBs that are located within institutions in neighborhoods with a large API community. I can't think of any independent IRB that's geared just to that. I don't know, Sherry, if you have any other experience.
Thanks, Amy. Yeah, so we do know of a couple, and certainly if whoever asks the question, please feel free to email Kate separately, and we can name a few. For instance, APJO in California, I know that they have they're an API-focused IR institutional review board, and there are a number of others. I think you're right, Amy. Most of them are inside of institutions that focus on Asia-Pacific Islander health, but they are out there.
Great. Thank you, Sherry. Any other questions?
I don't have a question, but this is Chris Harley with the initiative.
Okay. If there are no further questions, we'll go ahead and wrap up. Thank you, everyone, and thanks to the presenters for that really rich discussion.
Kate?
Yes?
Sorry, this is Chris Harley. I was wondering if I could just add a comment to the end of Sherry's presentation in regards to publications of research.
Absolutely. Please go. Please do.
Thanks. I just wanted to kind of note that I think it's important to think about different types of publications of research because, I think that the materials that Sherry was kind of talking about is kind of the research journal publication, but I would really encourage you also to think about publications for other audiences like advocates or funders or policymakers, and maybe to consider whether it makes sense when you're releasing your data to have folks with a non-research lens kind of help translate the results for those different types of audiences, because I do think that sometimes there's a disconnect between research that's presented in a very scientific manner and helping express the importance of that study for other audiences. And that's, sorry, just coming from a non-research person.
No, absolutely. That's a really great point. And I think what Chris is saying is that oftentimes as advocates, and I can speak if Chris, is that we do have a really rich data, and oftentimes that informs policy. And that is a really important point. If we translate it, as Chris said, in a way that informs our policy makers, whether it's legislators or our federal government policy makers or even state government officials. Thank you, Chris.
Mm-hmm. Great.
Again, I wanted to thank everyone. If you do have any follow-up questions, please don't hesitate to contact us, and our contact information is right there at connect@hepunited.org. Thank you so much, Chris, Amy, Karen, and Shari, for your time and your expertise. We will continue to have webinars in the months ahead, so for everyone, please be on the lookout for information about future trainings. And finally, when you leave the webinar, please look out for a survey to evaluate the training seminar today, and that is really important for us to continue to improve the experience for you. Thanks, everyone, once again for your participation, and have a great rest of the day.
Thank you.
Thank you.